Hello, in this video we will talk about benign mammary dysplasia, also called fibroadenosis or fibrocystic disease. It is a benign condition that causes increase in the number of cells or by growth of abnormal cells in the breast ducts or lobes. The true incidence in the population is unknown. It is common between 20 and 45 years. So let's go to the pathogenesis. The pathogenesis is uncertain, but it is probably hypersensitivity of the breast epithelium to normal circulating hormones, especially estrogens. The gross appearance of benign mammary dysplasia is that of a localized tissue mass with cysts of variable sizes containing bluish or green or clear fluid. Microscopically, benign mammary dysplasia is characterized by increased stromal proliferation, ductal epithelial hyperplasia, and some cyst formation. In the young group of patients, there is some group of glandular hyperplasia as well as adenosis. The clinical features: it is more common in nulliparous women. Pain or dull ache in one or both breasts, which may be worse in the luteal phase and is relieved by menstruation. So the menstrual cycle is made up of the follicular phase and the luteal phase. So the follicular phase is when there is a growth of ovarian follicle from day 1 to the 14th day until there is an LH surge and ovulation occurs around day 14th. And the luteal phase is when the cells of the follicle undergo changes by the influence of LH and is transformed into the corpus luteum. So the corpus luteum produces progesterone from day 14 to day 26. So from day 26, if fertilization has not occurred, the corpus luteum begins to get atrophied. It begins to become smaller in size and progesterone levels begin to drop down. And when the progesterone level begins to drop down, the corpus luteum may not be able to support and it will be shed out as menses. So in this case, what this clinical features is telling us, the increase in progesterone during the luteal phase makes the pain worse and it's relieved when there is menstruation, when progesterone levels goes down. A lump or lumps. So the next point is a lump or lumps often fluctuating in size, a serous or greenish discharge. On examination, the disease may affect the whole breast or be confined to part of it. Both breasts may be affected. The affected area feels lumpy in that it contains several small nodules which are more easily palpated with tips of the fingers. It is firm and usually tender and the surface is rather irregular. There is no definite edge and it has no attachment to skin or underlying muscle. A cyst may be palpable. Axillary lymph nodes are usually not enlarged. So I want to talk about something here on the examination. So an examination. So when you are examining any form of mass, so you are examining a mass, it could be lipoma, it could be fibroadenoma, it could be any form of mass around the body. So usually you use, when you're examining, use the site, all right? Use the site, the size, the surface, the shape of the mass, the consistency, the edges, whether it has smooth edges, whether, and then the next one is the tender, whether it's tender, whether it's not tender, whether the temperature, whether it's warm to touch, whether it's not warm, whether it has an original lymph nodes, whether there is lymph nodes that are enlarged around you. So always use this: the site, the size, whether it's 2 centimeter, whether it's 5 centimeter, the shape, the consistency, all right, the edges, the tenderness, the temperature, the lymph nodes. So let's go to the differential diagnosis. The differential diagnosis is carcinoma, fibroadenoma, duct ectasia. So the management will be excision for biopsy. So the next case is duct ectasia. Duct ectasia is the dilatation of the lactiferous duct which occurs close to the areola. It is seen in age groups between 25 to 70 years, but especially between 40 to 50. The dilated ducts are filled with yellow or brown cheesy material which can be expressed like a toothpaste. So the etiology and pathogenesis. The condition is due to fibrosis and aging of the periaquina and periductal lymphatics responsible for absorption of secretion of the achini. Only the fluid part is absorbed. So the clinical presentation: recurrent pain or discomfort in the breast, especially in the subareolar region. Nipple discharge. Remember when we were doing nipple discharge in the previous video, we mentioned that ectasia. It is probably the most common cause of nipple discharge. Retraction of the nipple from fibrosis resulting from the inflammation. Swelling under the area from gross distension. On examination, there may be tender induration or frank lump in the areola which have some or all of the features of adenocarcinoma, including nipple retraction, attachment to the skin, and axillary lymphadenopathy. Differential diagnosis. So most of these conditions are is diagnosed on clinical grounds. So clinically through history and examination. So it's always to have a differential diagnosis in mind. So the differential diagnosis of this one is adenocarcinoma of the breast, benign mammary dysplasia. So how will you manage it? How will you treat it after you go through the primary and secondary service of management of nipple discharge and breast pain? How will you treat? So the lump is excised for biopsy or histopathology. So let's go to lactational mastitis. It often arises as a result of cracks on the nipple due to the trauma of infant suckling. The commonest organism is Staph aureus. Resolution is often quick, but a small proportion of cases proceed to suppuration. An inadequately treated breast abscess may lead to chronicity without overt manifestation of its inflammatory origin. How will you treat it? So cloxacillin or flucloxacillin is very effective. Sarantibat is very effective. Failure to control the disease may complicate to an abscess formation. So let's go to traumatic fat necrosis. This condition is sometimes misdiagnosed as carcinoma but can be diagnosed positively on histological examination. Although it is supposed to be traumatic in origin, a history of trauma is unobtainable in most patients. So I decided to do a little bit of pathology here. So what is fat necrosis? Fat necrosis is due to the action of lipase on triglycerides, which releases free fatty acids, which combines with calcium to cause saponification. Example here is breast trauma. So in this case, there will always be a history of breast trauma, even though the patients they might forget to mention it, but always ask them when you are doing on direct question after the presenting complaints and the issue of presenting complaint. Ask them, do they remember if they've had any recent history of trauma, because most of the patients may forget to tell you that there was a history of trauma. So you always have to ask. On the clinical features, there is a hard irregular mass which may be attached to the skin but not usually to the underlying muscle. The surface is irregular and the edges is indefinite. So when you are talking about describing a mass, so I told you the size, the size, the surface, the shape, the tenderness, the consistency, the edges, the lymph node. So by using the same thing here, there is a hard irregular mass. So in the site that is found, and you mentioned the site, maybe the anterior lateral part of the breast, which you can mention. So there is a hard irregular mass which may be attached to the skin but usually not to the underlying muscle. The surface is irregular and the edges are indefinite. The nipple is not retracted and the axillary lymph nodes are not enlarged. So how will you manage traumatic fat necrosis? Excision and biopsy. So let's go to galactocele. So galactocele, it's a milk-containing cyst and develops during lactation as a result of blockage and subsequent dilatation of the lactiferous duct. It is usually sited under or near the areola, but may be in any part of the breast. It is painless of variable size. On physical examination, it is smooth surface, soft or tense fluctuant with definite edge and no attachment to skin or underlying tissue. An ultrasound of the breast will show a galactocele. Treatment: it usually disappears in few days with massage, and the baby should continue to feed. It may be aspirated. If it persists, excision biopsy must be done. Fibroadenoma. So let's use this vignette. A 23-year-old female presents to the breast clinic with a mass in her left breast. She discovered it whilst taking a shower. Her last menstrual period was 10 days ago. There is no family history of breast cancer. On examination, you find a palpable non-tender 3 cm in the upper lateral quadrant of the breast. The mass is smooth, well circumscribed and mobile. There is no skin changes, nipple discharge, or axillary lymphadenopathy. So the background: it's a benign tumor of the breast with epithelial and stromal changes. It develops during reproductive years and is an aberration of a developing terminal lobular unit due to hormones. They may enlarge during pregnancy. There is an estimated malignant change to carcinoma or sarcoma of up to 0.3, although fibroadenoma is generally not considered premalignant. Clinically, there are two types: pericanalicular fibroadenoma, which is the hard one, and intracanalicular fibroadenoma, which is the soft one. Pericanalicular fibroadenoma is much more common, and the peak incidence is much more seen in a younger women, peak incidence of 21-25 years, usually hard, oval, and about 1 to 3 cm in diameter. Clinically, it is firm, not attached to any tissue, and free mobile with smooth granular surface. So clinically, fibroadenoma, it is firm, not, and is freely mobile, not attached to any lymph, not attached to any tissue, and it moves freely, and there is no axillary lymphadenopathy. So intracanalicular less common, usually between 30 to 50, and grows less slowly. It looks like a cyst enclosing cauliflower-like masses. So what are your differential diagnoses? This condition is diagnosed clinically: fibrocystic disease, breast cyst, and galactocele. So the diagnosis is usually clinical, although through history and physical examination of the breast. So on physical examination, there may be firm or smooth, non-tender, mobile, well circumscribed, which moves freely. If it's tender, please, it's not fibroadenoma. Fibroadenoma is always non-smooth, non-tender, and it's well circumscribed, which moves freely. So the treatment is excision and biopsy. So thanks for thanks for your time, and next video, I'll see you in the next video.